welcome I'm Albert Carnesell, Academic Dean of the Kennedy School of Government. This is the second in the series of symposium marking the university's 350th anniversary and the Kennedy School's 50th. And in each of the symposia here at this school, the sponsoring organization is one of the research centers at the school. And this symposium on Medicare coming of age is being sponsored by our Center for Health Policy and Management. The moderator today will be Dr. Julius Richmond, a former Surgeon General of the United States, a professor of health policy and management here at the university, and director of the university's division of health policy. So it's my pleasure to say welcome to all of you, and to turn it over to Julius.
Thank you very much, Professor Carnesell. It's a delight to add my words of welcome on this occasion of the 350th birthday of this university. 50th birthday, as you just heard, of the John F. Kennedy School of Government. And when we talk about 50 years of this school, one can't help in the presence particularly of Secretary Cohen to recall that that corresponds pretty much to the period over which we have had Social Security legislation in this country. Now, some 30 years after that legislation was enacted, as you know, and what we're here to discuss today, we had the enactment of an amendment to that legislation, Title 18, the Medicare legislation, a program of great significance for the nation. And the title of today's symposium is Medicare Becoming of Age. And as a pediatrician, I would observe that the title is probably quite appropriate because 20 years doesn't quite confer all of the maturity that one would like, so we will be focusing today on what we have learned as a consequence of the 20 years and what we look forward to for the future. And I would just like, in introducing the symposium, to pay tribute to Pam Blumho. She was just in the room for having made the arrangements and been so helpful in the recruitment of the members of this distinguished panel today. So we're very much in her debt. Now, in the Division of Health Policy and in the Kennedy's Center for Health Policy and Management, over the past 2 years, we have been very much occupied in a study of Medicare. That is what we have learned over the past 20 years, and we issued our report somewhat earlier this year, and you'll be hearing a bit about that from one of the members of the panel. Now, we have very limited time. We have asked the speakers to be relatively brief so that we may have some time at the conclusion of their presentations for questions from the audience. And so we do hope that there will be that opportunity for some exchange among the members of the panel and also from the audience with members of the panel. I would suggest that you hold questions and comments until all of the panelists have made their presentations, and at that time we'll then open the floor for discussion. And the first presentation on the panel is from an old friend, and we're often inclined to say that he's a friend who was there at the creation. People often pop their eyes when we say that, but we mean the creation of Social Security in this nation, and he was also there at the time Title 18 was passed, very central to the passage both of that act and also that of Title 19. He now is the Professor of Public Affairs at the Lyndon Baines Johnson School of Public Affairs of the University of Texas at Austin. But I think many of us remember him particularly in terms of the very significant contributions he has made over so many years, both in and out of government, but particularly during the years he served as Undersecretary and Secretary of the Department of Health, Education, and Welfare. So, Professor Cohen.
My task, I believe, this afternoon will be to set the historical perspective on which the other speakers may build and to refresh the minds of some of the older people here of what happened and to tell some of the younger people who have no idea what happened, what did happen. I came to Washington in 1934, as Dr. Richmond said, to help in the drafting of the Social Security program. So I have about 50 years of experience, along with the Kennedy School here, in working on these problems. And my only hope is that I can come back 50 years from now and see what's really happened to all these programs. I did participate in the drafting of the first national health insurance laws, known as the Wagner-Murray-Dingle Bill of 1943, which was castigated by the American Medical Association for being an entering wedge to socialized medicine. And as a result of that experience, and because of the collapse of that legislation in 1950, when President Truman had recommended it, I was asked if I had another alternative by the political leaders at that time. And I said, yes, I did have another alternative. I didn't know how good it was, but it was to just limit health insurance in the United States to aged people who were not then primarily cared for by private insurance. As a matter of fact, in 1948, 49, 1950, there were only about 20 or 25% of the American people 65 and over who were covered by private insurance. So 3/4 of the aged had no private insurance of any kind. Plus the fact that the insurance companies who sold it were losing money on it because their actuarial estimates did not disclose the true nature of the demographic increase in the number of aged, and the fact that aged people on the whole have 5 to 6 times as much per capita medical care expenditures as people under 65. So they were rather anxious to find some kind of a substitute, and my suggestion about what we later call Medicare came into being in 1950 with nobody very much interested in it for about 7 years, until a member of the Ways and Means Committee, Mr. Forand, introduced it. And as a result of that particular type of pressure, the Kerr-Mills legislation of 1960 was enacted on a welfare basis to provide aid to the aged. That was unsatisfactory to the politicians and to the American people, and some other substitute needed to be undertaken. And as a result of that, of course, the Medicare program came into became a realistic proposal in the election campaign of 1960, and when Mr. Kennedy and Mr. Johnson were elected, Medicare became a large part of that. At that time, President Kennedy appointed me the chairman of the commission called Health and Social Security to make a report on it, and it was pretty well ordained that I was going to recommend Medicare and these other programs, and President Kennedy-elect approved that on January 12th of 1961. It became a major part of the Kennedy-Johnson administration and ultimately became President Johnson's central part of his plan in health care, along with a lot of other legislation. The point I'm going to make 2 points in connection with that brief historical account. One, the vehemence with which the American Medical Association and individual physicians attacked the program. I can see some people in the room who can nod about that, but many of the young people today will wonder why such a rather innocuous thing as Medicare that at that time would have been viewed with such animosity, such hostility, such fear, such anxiety as an entering wedge to Soviet collective medicine. There is a famous picture, this was attacking the Wagner-Murray-Dingle bill in 1943, but the same thing applied, that before you would get medical care under this legislation, you would have had to apply to the Surgeon General, and since Dr. Richmond was one Surgeon General, you would have had to apply to the Surgeon General to get into a hospital, just like, you get a ticket at the meat market or the grocery store or something else. And then every doctor would have to call Washington to see if he could, get you in the hospital, and every doctor would make you stand in line. I could recount, for an hour or so all of the things that were said. I could even recount what they said about me. The net result was that, of course, we got into a very, very difficult political situation in which the physicians represented by the AMA would have nothing to do with the legislation, would not even talk about it in terms of constructive suggestions, although the American Hospital Association did so. At that time, we were beginning the crisis in hospital care, and the American hospital people, without necessarily agreeing to it, did give professional advice as to how it could be done. And that really made the hospital part of what eventually became Medicare a rather professionally good base. But, as you know, there was a great deal of public support for doing something for the aged because so many of them were excluded from health insurance. And as a result of this constant barrage, I would say, by the federal government, of which I was a part during those years, we will take credit for at least one thing. The private insurance companies sold more private insurance. I think that a great deal of the developments from 1945 and 50 in the sale of private insurance grew out of the fact that finally the American Medical Association and the private insurance companies felt they had to do something. I'd have to recall to you that in 1932, when the Committee on the Costs of Medical Care made its famous report, they said it was impractical in the United States, in effect, to have private insurance. There was no statistical or actuarial base, and there wasn't much at that time, I'd have to admit, too. And even into the late 40s and immediately after World War II, the possibilities of selling private health insurance was viewed as a rather distant, possibly unprofitable, and certainly less than statistically accurate thing to sell. But the constant barrage of those of us who were party to saying we had to do something in the United States about taking care of people's health insurance gave rise to the private insurance and gave rise to significant changes in the AMA in trying to underwrite some kind of a program. The difficulty was that the AMA didn't decide until about January of 65, probably immediately after November 2nd, 1964, they made the decision, but it took them the month of November, December to decide on what the program was, and they came out with plans for more comprehensive care, saying that the trouble with Medicare was that it was only related to hospitalization, which was a good criticism. Except that when Congress finally took the criticism, they said, well, if your criticism is valid, we'll make it bigger and broader. That isn't exactly what the AMA had in mind. But as a result of that, Wilbur Bills added on what we today call Part B of Medicare, that is the physician's voluntary insurance coverage, which is virtually universal in its application for people 65 and over. So the AMA proposal, coming too late and making a sort of an attempt at a fatal argument about the narrowness of the system, only reacted to make Congress make it broader and cover physician services, which they didn't really want. The second thing, though, that I want to want to recall because it's still present today. There is one thing that keeps coming up all the time, at least in the minds of a large segment of the 500,000 physicians of the country and a lot of other people. And that is, why provide Medicare to wealthy people? Why provide a government program of insurance to people who ought to be able to take care of it themselves? Well, what's the alternative? What's the option to that criticism? To make it only for low-income or poor people. That's exactly what the bulk of the American people don't want. They don't want a welfare program for these. So that the balancing of that particular argument, which was present all the time, as a matter of fact, in the 60s, when I would talk to the few medical groups that I was ever invited to talk to, the predominant question would be, why do you extend it to people who can pay for it themselves? And the point we would make is that we wanted to have a classless program. We wanted to have a program that had no stigma to it. We did not want to distinguish between rich and poor. We didn't want to talk about those who were worthy and unworthy, which had been the remnants of the Elizabethan poor law in the United States and still are in the welfare program. But that issue still remains present today, and you will hear it time after time. Why don't you amend Medicare to make to either exclude the rich or only relate to the poor or have an income test or make it welfare or provide some kind of a different financing to it that would have a welfare aspect to it? That, I think, is still one of the big political questions. It may not be the most important in terms of substance, but here, 20 years later, the same issue, I think, is present. Now, in the short time I have left at my disposal, I would say this. I think Medicare has done better than I thought when I first developed the idea in 1950. But quite frankly, I would have thought by this time that we would have had a national health insurance covering everybody. That has not happened. I think that is my greatest disappointment, that we still have 30 or 35 million people in the United States who have no health insurance whatsoever. A large part of them, which are the indigent, the poor, for whom you pay their costs in your hospital care because of cost shifting. When a hospital takes care of poor people, they have to make it up. The loss leaders have to be made up by the people who can pay. So it isn't as if you're escaping the payment. But we have a rather two-tier financing system of medical care, which I had hoped would have passed by this time. And I only make one prediction. By the time the Kennedy School celebrates its 100th anniversary, we will have a system in the United States that will cover everyone. I don't know what kind of a system it is, and there are about 10 different ways that it could be achieved. And it may not be, and I don't think it will be achieved by the Wagner-Mary-Dingle method of universal national health insurance of 1943. There are new options on the table. But I do not think the United States of America, which is the only country other than South Africa that doesn't have a comprehensive health payment system. I don't think that's going to continue, and I think it will be changed by, 1996. But it's going to be a very difficult thing, because with all the problems we have now and all the problems Dr. Roper has about financing medical care and the federal budget and the federal deficit and growing medical care costs, it's very difficult to figure out a way that the American politicians and the American public are willing to take on this problem of assuring the other 20 or 30 million people to be covered. The other problem is there's probably another 10, 20, 30 million people who have some kind of a health insurance program, very limited, so that if they do have some kind of catastrophic health insurance, they are only partially insured and they become the bad debt or the indigents in the hospitals or the non-payment, non-resource people or physicians. I look upon this last 20 or 50 years, therefore, in the way of a great American experiment. What we have been going through is a period of trial and error. that is so typical of our American pragmatism. Namely, get your big toe wet and then see where you go from there. Well, we've now had 20 years of experience with Medicare and Medicaid. And I would think the experience, which we're not analyzing today, of Medicaid, which is a welfare-oriented system, is proof of what I think is an important edict in medical care. If you've got a system only related to the poor, it's going to be a poor program. And as strong as I am in favor of the Medicaid program, which I developed in connection with Medicare in 1965, and as strong as I would be to advocate to Dr. Roper that the Reagan administration ought to improve it because the poor people are alive today and need it, I am not for the permanent extension of a welfare system for medical care in this country. I think it is a disgrace to a country as affluent, as powerful as the United States, to have 22 million people in this country today getting medical care because they're poor, and having another 22 million or so who are poor and can't get medical care under the Medicaid system of the various states. So I believe our analysis today leads us to the point that we've got to find a better way in the United States to provide comprehensive, high-quality, financially viable health protection for the American people. I don't think it's impossible. I think it's very difficult. I think it's going to take the most creative type of federalism. It's going to take the most creative type of relationship with the physicians of this country. But there's one good thing about it. There are too many physicians in the United States right now. Over 500,000 of them. They're going to be competing for the jobs. They're going to be competing for it. And in the next 10 years, they'll become a little bit more willing to accept major changes in policy that previously, 20 years ago, they were vigorously objecting to. So I look forward to the future with some degree of optimism. I think the experience that we have indicates we can administer this program. I think the experience indicates that we have a lot of problems, but we can survive even with the problems. I think the experience indicates that we can't go on having this big division between the poor and the middle class and the rich. And I think with the wonderful medical care system that we have in the United States, we can do better than we have up to now. And I'm rather confident that it may not be in my lifetime, but I think it'll be in the lifetime of some of you young people here today. Thank you.
Thank you very much, Professor Cohn. Our next speaker I first came to know, and he was a county health officer, Jefferson County, Alabama, and we called on him for a good deal of data when I was Assistant Secretary and Surgeon General in Washington, and he was always very obliging in providing it for us. He came to Washington in 1982 as a White House Fellow, stayed on the White House staff as a Special Assistant to the President for Health Policy, and earlier this year he became the 5th Administrator of the Healthcare Financing Administration, which brought together the two programs that Professor Cohn has mentioned under one administration, Medicare and Medicaid. And I should add, it's a particular pleasure also to introduce a fellow pediatrician, Dr. Roper.
Certainly my pleasure to be here this afternoon and to join this distinguished company to talk about a very important subject. Medicare today is a matter of national concern. We are facing a number of issues, many of which we will touch on today, and in my remarks will only touch on a few of them. But I think the central question is how can we provide quality health care for the elderly and disabled at a price we can afford as a society? How do we balance compassion on the one hand and cost on the other? I don't think anybody in this room believes that health care policy should be dictated solely by economics. I certainly don't, though some of my best friends are economists. I feel the same irritation that I'm told Winston Churchill did when he heard a social planner talk about houses as accommodation units. When we talk about health policy, it's not just economics. We're talking about some of the most personal and sensitive of all human needs. But economists are right to this extent. The laws of their discipline apply as much to health care as to any other commodity. Human wants are insatiable, but human resources are scarce. And that means one thing, that society must make choices, often very difficult choices. The only real question is who is going to make those choices. Should it be, on the one hand, a few thousand bureaucrats, however well-meaning, and I call myself a bureaucrat, a few thousand of us in Washington, or should it be, on the other hand, millions nationwide whose vital interests are at stake in these issues, employers, unions, insurance companies, health care plans, doctors, hospitals, and finally, and most importantly, individuals and families? I think it should be the latter. The matter of choices is what I hope to talk with you about today and emphasize the importance of decentralizing those decisions and those choices. I would maintain that Medicare went wrong when government tried to make private choices unnecessary. It's well known that the threat of or promise of government intervention can have a paralyzing effect on the dynamism of a free society, and so it is with Medicare, although that's certainly not what the authors of the Medicare statute intended. But I think in creating this program, leaving the private medical care system largely intact, made the government responsible for the reasonable health care bills of the nation's elderly and disabled. What that has led to, 20 years later, has been a virtual blank check for the payment of those bills. That's what I mean when I say that government tried to make private choices unnecessary. What incentives were there? And there were none for providers or consumers of health care to be economical, to make choices, because the federal government was picking up the tab. At the best, the fee-for-service, cost reimbursement way of paying for health care services had no incentives for controlling costs, and at worst, it opened the door to overcharge and to abuse. And you know what has ensued from that. The costs of the program have doubled and redoubled every few years. There have been repeated efforts to control those costs through various forms of regulation, all to no avail. First of all, because the job was too big for any single government agency to handle, and secondly, because regulation can never control costs as effectively as can market incentives. At the one time, it was heresy for a federal official to say such a thing in public, but now I think it's conventional wisdom, at least it is in Washington. Those of you who've seen Joseph Califano's recent book, America's Healthcare Revolution, are aware that a profound shift in attitudes has occurred. Mr. Califano, of course, was a protege of Mr. Johnson, and our distinguished guest here. He was secretary of HEW under President Carter and was an enthusiastic proponent of both national health insurance and government regulation of hospital costs. But here's what he's saying now about the role of government in the private sector. I quote from his book, "For more than a decade, I was convinced that the job of reining in healthcare costs was too big for the private sector, that only government could do it, and that government had to do the whole thing. My years at HEW and 6 more outside government lead me to believe that, in the important part, the great hope of containing healthcare costs lies in an aroused private sector." Mr. Califano certainly profited from his years in the private sector, especially assisting the Chrysler Corporation as they implement changes in their employee benefit plans. He goes on to great lengths explaining what they're doing at Chrysler, and in fact right now we are working with Chrysler to look at some possibilities of building on their experiences in the private sector to link up with what we're doing in Medicare. Such things as competitive bidding, second opinions, generic drugs, and other techniques, all of those things boil down to a simple, single word, choice. And again, that's what I want to emphasize. There are many issues that we could talk about. I'm pleased to hear Professor Cohen's introduction. What I'd like to do, though, is focus on the future and where we think we ought to be headed in the future with Medicare. The Reagan administration has been successful in holding down the cost of the program precisely because it's no longer shielding the private sector from the need to make choices. Prospective payment for hospitals under Medicare is one example of this. You all, I'm sure, are familiar with the intricacies of the DRG system, so I won't burden you with that. But simply, we give hospitals a strong incentive for them to make choices about how to manage themselves in the delivery of health care services. And the evidence to date is that that's having an effect. Prospective payment is one of the main reasons why the rate of increase in health spending last year was the lowest it's been in 20 years. But for all its virtues, prospective payment has some central flaws. It's cumbersome, it's arbitrary, and it involves the federal government too deeply in the actual practice of medicine. Furthermore, while it represents an improvement over the old cost reimbursement system, it's not the best way of keeping costs low and quality high. Prospective payment commits the government to making decisions we in government are not well equipped to make. For example, we continually are facing the issue of how to revise the DRGs to accommodate new advances in medical science or changes in the practice of medicine. There are exceptions, inevitably, even with 470 diagnosis-related groups. Not everything fits within that, especially not new technology. Each exception we make makes the system more complex, more difficult to administer, and I'm fearful that one day it's going to collapse in all its complexity. Prospective payment has been a very useful stopgap measure, but we need a more effective and lasting solution for the long term. And we're phasing in that solution right now. It's not a panacea. Tough choices still have to be made. But the solution, I think, is to ensure that the right people are responsible for making tough choices. Last year, for the first time, Medicare beneficiaries were allowed to opt out of the traditional Medicare program and to enroll in private health maintenance organizations or competitive medical plans. These operate on a capitated basis or a so much per patient basis. The plans receive a lump sum for the total care of a patient over a period of time. When a Medicare beneficiary enrolls in such a plan, the plan is paid an amount equal to 95% of what would have been spent on behalf of that beneficiary. The plan then is at risk and is given a strong incentive to keep the patient healthy, to use preventive techniques, to keep them out of the hospital, to treat them at the most appropriate level, to make sure they get well as quickly as possible. Medicare beneficiaries find these competitive medical plans appealing. They provide convenient, comprehensive, one-stop health care coverage, which just isn't available in the standard Medicare program. Because, after all, Medicare doesn't cover all medical expenses. There are significant deductibles and co-payments that are burdensome to the very ill beneficiaries. In an HMO or competitive medical plan, these amounts are generally much smaller. These deductibles and co-payments sometimes don't exist at all. In fact, some of the plans offer additional benefits like prescription drugs or eye examinations and so on that are not covered by the Medicare program. This approach to financing healthcare services is called capitation. It's a burdensome word, one that I have been charged for the last 3 years with finding a replacement for, and I confess my frustration that I haven't yet succeeded in finding a better expression, because to many, capitation has a negative ring. People misunderstand that what we're talking about. They misconstrue this as being like the British national health system, in which a doctor is paid under a system they call capitation, but we're talking a different thing. We're talking about individuals enrolling in private plans that are paid a fixed amount that deliver services in a way that allows choices to be made close to the level of the person receiving those services. We're not and don't intend to force change on anyone. Medicare beneficiaries have the opportunity to stay in standard Medicare or to choose amongst an array of these private plans. We're also giving freedom of choice to the healthcare community, to doctors and hospitals, whether to become affiliated with these plans. As it now stands, Medicare has enormous, what the economists tell me is called monopsony power, that is, the golden rule. Whoever has the goal makes the rules. Well, right now, ladies and gentlemen, I have the goal, and we are daily making the rules about the practice of medicine to doctors and hospitals under this new system of capitation that I'm describing for you. Doctors and hospitals will be able to negotiate, to make deals with these plans, HMOs, competitive medical plans. That'll be a much different world, and I think it'll be one much to the benefit of Medicare's beneficiaries. Under such a capitated Medicare program, there'll be competition amongst these plans to enroll beneficiaries, to treat them well, to treat them humanely so that they stay enrolled from year to year. And the plans then will compete for the best doctors and the best hospitals in the community. This will harness the creative powers of the private sector to produce significant gains for all participants. The government will gain in that I think the system will be run more efficiently and ultimately should lead to a less costly program, or at least costs will not go up as rapidly. Doctors and hospitals will gain in that they'll have greater freedom to exercise their professional judgment. Instead of being paid on a piecework basis, they'll be paid for what we as preventive medicine specialists have said they should be paid for all along. That is to keep someone well, to watch over the total health care needs of an individual. The fee-for-service system, with its fragmented nature, works in just the opposite direction. Lastly, and most importantly, this new system will be of enormous benefit to those enrolled in the Medicare program because of the choices that they will have, many more choices than they currently have. Now we're giving this capitation idea a market test, if you will, under Medicare. Since a year and a half ago, 600,000 people over 65 have chosen to enroll in such plans. That number continues to increase dramatically. And we want to broaden the kinds of plans that can participate. Senator Durenberger has introduced a bill for the administration in the Senate which would expand the kinds of plans that can participate so that insurance plans, employer-based plans, union-based plans, for example, can participate in the program. Senator Durenberger's bill would also eliminate some of the restrictions that apply so that there will be even more expanded choices, more opportunities. Private health care plans would no longer have to provide a single set of benefits. They could tailor themselves much more to the unique needs and wants of individual beneficiaries. I think this sort of future that I pose for the Medicare program offers the opportunity, the promise for what we have been looking for these 20 years now. We have many other possibilities on the horizon. I think there are some unanswered questions at the moment under the scenario that I paint for you. We're quickly doing the research and demonstration necessary to answer those questions. But I believe that capitation is a practical means for dramatically improving the Medicare program. Through it, we can redeem the bright promises that were made when this program was launched 2 decades ago. Thank you.
Well, thank you very much, Dr. Roper. Our next speaker, I take delight in welcoming back to Harvard. I say back to Harvard because this is where he received his degrees. He is currently a senior corporate fellow at the RAND Corporation and a faculty member of the RAND Graduate School. He's also an adjunct professor at the Schools of Medicine and Public Health of the University of California at Los Angeles. And so it's a great pleasure to introduce Dr. Jeremy with us.
The future of Medicare is almost certainly going to involve continued change. The problem is that we want two things, and we can't get as much of each as we want. As a result, we're likely to keep trying methods that give us more of one or more of the other, or if we're really very clever, maybe a little more of both. These two things go under code words in the political debate. One is usually called efficiency or cost containment. The other is usually called access. Now, we're used to thinking about access as a problem for the poor or for people who don't have insurance or whose insurance isn't very good. But in the future, we may be talking about access as a problem for other kinds of people. Before I get to that, you may be wondering why it's so hard to have both efficiency and access. I think that's easiest to explain by looking back at the history of the Medicare program. We had almost 2 decades of relative stability in the program, and then we began a small revolt in 1982 that blossomed into a full-scale revolution in 1983 with the enactment of the legislation that brought about the prospective payment system. So let's, in this retrospective, take a look first at the relatively stable period from 1966 to 1982. Medicare began with the goal of taking the financial worry out of sickness, and to a large degree it succeeded in that goal. The most glaring exception is people who need to spend much of the rest of their lives in nursing homes. But despite that exception, Medicare was a godsend to many elderly people who prior to 1966 either couldn't get insurance at all, as Secretary Cohn described, or who couldn't afford the premiums. Medicare was, and I think it largely still is, seen as an enormously successful government program. For example, for many years, the late Senator Jacob Javits proposed legislation that would have brought about national health insurance simply by sending Medicare to everybody. Now, one of the keys to Medicare's early success was that almost all doctors and hospitals were willing to treat almost all its beneficiaries. They were willing to do so because, unlike its sibling Medicaid, Medicare essentially paid a going rate to hospitals and doctors. Specifically, it reimbursed hospitals its share of costs, and it paid doctors what Medicare considered to be a doctor's reasonable fee. Although many doctors may grouse about what Medicare pays, in fact, doctors accept Medicare's definition of reasonable about 70% of the time, and they're free to charge more than that the other 30% of the time. In some, paying the going rates meant good access. But the price for this ease of access was steep. Because Medicare would pay for virtually any medical treatments that could be shown to improve health, as did private insurance, physicians, researchers, developers, and entrepreneurs had a much stronger signal to develop new procedures and new products than did developers and entrepreneurs in the rest of the economy. Let's look for a minute at the calculation of entrepreneurs outside of health. Think, for example, of a firm that makes personal computers and is considering making a new printer. Now, in order to invest in this project, the firm has to believe that consumers will pay enough for the new printer to recover the cost of developing it. If the printer is only a little better than what's on the market and the development costs are high, the firm may decide not to invest in the new printer and will never see it on the market. But health was different. If there was a new pacemaker, say, the price mattered rather little because it could get passed along to insurance. What happened? We saw a veritable flood of new technology and new capabilities, ranging from artificial joints to radiation therapy to much more sophisticated and safe diagnostic techniques such as magnetic resonance imaging and much, much more. We also saw some waste. But it was primarily the flood of new technology, not waste, that led to the sustained rise in cost that is now widely decried as excessive. In short, we had very good access, but we weren't sure we wanted to pay the price. Time to turn to Chapter 2. As the proportion of GNP in health rose to exceed 10%, Congress decided in 1983 to change the rules. The old rules hadn't really imposed much budget discipline on medical care. When it came to health, we acted pretty much as if cost was no object. By contrast, the new rules were that hospitals, at least, should have limits of sorts. These limits were introduced in the form of fixed payments for diagnoses. Alternatively, some beneficiaries, as Dr. Roper described, joined up with health maintenance organizations who agreed to provide medical care for a fixed fee per year. These new rules have, in fact, changed behavior. Hospital lengths of stay among those over 65 have fallen by 10% in just 2 years. That's a historically unprecedented rate, and even admissions are falling. Now, that latter wasn't expected, but that's another story. In most quarters, although not all, these things are taken to mean more efficiency. That is, what we wanted, we're getting. Now, these new rules are also leading to different kinds of calculations by both entrepreneurs and doctors. Entrepreneurs are starting to make similar calculations in medical care to those made by computer companies and every other company. They may now not bring out some products because they can't recover the development costs, unlike the old days. The pace of innovation is likely to slow somewhat, but in principle, the innovation that will be cut back will be the kind that would be expensive and provide relatively little in the way of benefits. So this slowing down is probably a good thing. It's not only entrepreneurs, but also doctors who will adjust their behaviors. For centuries, doctors have sworn to do everything possible for their patients, and today's doctors have mostly been trained this way. The problem is that for many centuries after Hippocrates, doing everything possible really wasn't very expensive. Didn't mean giving up very much, but the flood of medical innovation has changed all that. Under the new rules, doctors are going to increasingly have to make conscious choices about what's worth doing. Doctors aren't very comfortable with this unwanted role, and the unsettled state of liability law only heightens their anxiety. Nonetheless, I expect that doctors will increasingly not do some procedures or not order some tests and not admit some patients that they would have done under the old rules. But my main point is that as we strive to get more efficiency, it's hard to avoid creating access problems for people that didn't used to have them. And I want to explain why by an analogy. I want you to imagine that you're rolling your supermarket cart down the aisles. If you have on your list a box of Cheerios, a six-pack of Coca-Cola, some apples, and some bananas. You breeze down the breakfast cereal aisle, you quickly grab a box of Cheerios, you find the soft drinks, you pick up a pack of Coke, and you head to the produce. Now, when you get to the produce, you slow down a little bit. When you find the apples, you don't just throw a few in your cart. Rather, you pick up each apple to see if it's bruised. After you've found a few that aren't, you wheel the cart over to the bananas. Here, too, you have to dig a bit because most of the bananas seem overripe to you. But after a minute or so with the bananas, you're ready for the check stand. Now I want you to think about the breakfast cereal, the soft drinks, the apples, and the bananas that are left for those compulsive workers who can't find time to shop until just before closing. If they only need breakfast cereal and Coke, they won't have a problem. What they'll get will be similar to what the early birds got. But the chances are that the apples and the bananas they'll find won't be just like the ones the early birds got. The bruised bananas and the overripe bananas, the bruised apples and overripe bananas will be what's left. Now, why do people linger over produce and not over breakfast cereal? Because there's a fixed price per pound for both, but boxes of Cheerios are homogeneous and pounds of produce are not. And how does this apply to medical care? Well, to spur efficiency, we're trying to impose fixed prices, but those prices are for heterogeneous products, namely people and their medical problems. Patients who are predictably expensive will not be welcome at all doors. They'll be like the bruised apples, and they'll tend to be left on the produce stand. For example, patients who have heart attacks that cost more to treat than Medicare will pay could have an access problem. To be sure, because Medicare pays the average amount, hospitals in the aggregate will be all right. That is, the profitable patients ought to offset the unprofitable ones, the losers. But any individual hospital can improve its bottom line by cutting down its proportion of users to the degree it can forecast that a certain patient is a loser. How could it cut down? It would try to get the patient to go to another hospital. Could that be stopped? If the hospital were subtle, it might well go undetected. In fact, it only has to get a few percent of the potential patients to go elsewhere, provided they're the right few percent, because about 1% of the patients account for a quarter of the expenditures. Those patients who were welcome under the old rules are now like the Queen of Spades in a game of hearts. Anyone who ends up with them is heavily penalized. But isn't trying to send patients down the street unethical? Many will think so, but undoubtedly some will say if it's legal and profitable, it's okay. So they will start to engage in such behavior. They will indeed make money, but the others who are trying to be ethical will not. Indeed, it may happen that everybody who wants to stay in business will either have to start acting that way or else will have to find ways to cut down on the amount of services these very sick patients get. For those of you who remember the 1940s, the situation is analogous to Blue Cross's having to abandon community rating as commercial insurance companies entered and experience rated. Suppose we said there ought to be a law. And we tried to write regulations to prohibit doctors and hospitals from discriminating among patients. I suggest to you that if I'm a doctor, there's lots of ways for me to convince you to go somewhere else that are beyond the reach of regulations. I can answer your questions in a way that makes you wonder if I really know what ails you. I can keep you waiting. I can be a little curt with you or even rude. So maybe there ought to be a law, but I'd hate to be the person that had to enforce it. Right now, I don't know of a system that we can readily implement that seems likely to give good incentives for efficiency and will pose no access problems. People at universities and research institutes are trying to find better methods than we now have, and they almost certainly will, because this problem hasn't been worked at for very long. But the sad truth is that the problem is very difficult, and we in other countries are likely to be working at this for a long time. Thus, I come back to my opening assertion that the future of Medicare is likely to be continued change. My guess is we'll try new methods to obtain more efficiency, more access, or both. And from time to time, we may decide we want to have more of one and less of another. But I rather suspect that 4 other people will be able to have an interesting dialogue about the financing and organization of medical care on Harvard's 400th birthday.
Worked on the Senate Health Committee as a staff member and was very instrumental in the drafting of a number of bills in relationship to health care in this country. He came back to Harvard from his work as a staff member of the Senate Committee and has been the executive director of the Center for Health Policy and Management here at the Kennedy School. And I had the great privilege this past couple of years of serving as co-chairperson with him of our Harvard Medicare Project Committee. And so it's with a great deal of pleasure and appreciation that I introduce Dr. David Blumenthal. David?
Thank you, Julie, for that kind introduction, and I'd like to, on behalf of the school and on behalf of the Harvard Medicare Project, again, thank our panelists for attending this symposium on the 350th anniversary of the university. I'd also like again to thank Pamela Grunholler, whose work in organizing this conference and this symposium has been superb. I had intended to thank her especially for putting me on the far right on the panel, since I thought it might give the appearance of balance to the presentation I was going to make. Fortunately, I should have known that Wilbur Cohen would have made that comment unnecessary. I'm not going to talk about national health insurance. We in the Harvard Medicare Project confined our thoughts and comments and recommendations to the Medicare program itself. But I think you will notice a difference in tone to my comments in that we have addressed ourselves not solely or perhaps even primarily to the cost side of the dilemma that Joe Newhouse so ably demonstrated, but perhaps have placed somewhat more emphasis on the access side of that dilemma in trying to come to grips with the demographic imperatives that our society faces with our aging population, and also in trying to come to grips with the problems of elder Americans at the current time, which are so graphically illustrated by a number of recent stories which you all, I'm sure, have read in your local newspapers or heard on your local television reports. And let me just take a couple to make the point more graphically. In October of 1985, the Boston Globe, our local version of the New York Times here in Boston, carried a story about an 80-year-old Cape Cod man who was sentenced to 1 year's probation for smothering to death his bedridden, paralyzed, and mute wife. And the story quoted his minister to the following effect: I think John felt a terrific financial pressure in that he couldn't afford to send Olive, his wife, to a nursing facility.
This has been a devastating experience for him. And then the New York Times itself, in March of this year, carried another story reporting that increasing numbers of elderly Americans are suing their spouses in nursing homes, that is, the spouses who are institutionalized, for the support of the non-institutionalized spouse. And the reason they're doing so is that those support payments do not count as assets in totaling up the assets of the institutionalized spouse. And so therefore, that institutionalized individual can be eligible for Medicaid without becoming destitute and without sacrificing the living expenses of the spouse who's not in the facility. These stories illustrate the kinds of problems that our country is now facing. These problems pertain not only to our growing long-term care crisis and our catastrophic health care crisis, but to problems related to acute health care as well. At age 20, the Medicare program has done a great deal to promote the health and well-being of the American people generally, as well as the elderly population. Nevertheless, the program has serious deficiencies that, if uncorrected, will leave more and more aged Americans unprotected against the financial burden of illness and without adequate access to needed health care services. The Harvard Medicare Project saw the 20th anniversary of this historic program as an opportunity to take stock of its record and to propose needed reforms that we thought would carry it into the 21st century and preserve its integrity. And it's some of those findings and recommendations that I'd like to share with you today. First of all, one of the deficiencies of this so costly, this Medicare program that we all decry is excessively costly. What are some of its deficiencies? First, the Medicare program is needlessly complex in its current form. It consists not of one program, but two, one covering hospital insurance, the other primarily physician care. Each program has its own set of intricate regulations governing co-insurance and deductibles, appeals processes, exclusions from coverage, eligibility for coverage, methods of paying providers, and other matters. As a result, too many elderly Americans do not understand what Medicare covers and what it doesn't, cannot predict how much their health care will cost, and don't even know where to go to find out. These problems have almost certainly been compounded by what on its face seems an admirable efficiency in expenditures on program administration in the Medicare program. Right now, expenses for program administration constitute 2.5% of the cost of the Medicare program. The average for the private health insurance industry is 7%. The average cost of processing a single claim, that is a bill submitted by a physician under Part B of Medicare, has fallen by 66% in real dollars in the last 14 years. We could rejoice over this if it weren't for the evidence, the growing evidence, that services to beneficiaries, for example, the amount of time it takes to process a claim and the amount of time it takes to hear an appeal about a disputed service, those kinds of services are suffering as a result. Second, the Medicare program fails to protect elderly Americans adequately against the cost of covered services. This despite its great cost. As a proportion of beneficiaries' income, co-insurance and deductibles have almost tripled since the program began. We estimate that each year 2.5 million elderly Americans incur more than $1,000 in out-of-pocket expenditures each year. That exceeds their average discretionary income in many cases. In the last year, the hospital deductible under Medicare alone increased by 23% and is increasing by a nearly comparable amount in 1986 and 1987. Elderly Americans now pay 15% of their income annually for their health care bills, which is about what it was before the Medicare program was passed. And in 1986 and 1987, the proportion of their income that they spend on health care will almost certainly exceed what it was before Medicare was enacted. The Medicare program is unfair to low-income elderly, who on average pay 1/4 of their income annually for health care, as compared to 3% for high-income elderly. Medicare fails to cover essential services. It does not pay for chronic home health care or nursing home care. It provides fairly minimal mental health coverage, and it fails to cover many essential primary and preventive services. For services that Medicare does cover, it often pays providers too much, something we talk about a great deal, or it pays them in arbitrary and capricious ways that result in inefficient behavior. From 1979 to 1984, the cost of physician services under Medicare increased at an average annual rate of 18.5%. And despite a freeze on physician fees in the last year and a half or so, expenditures on physician services in 1985 increased at 3 times the rate of inflation. Because of these and other deficiencies, we in the Harvard Medicare Project concluded that the program is less equitable, more complex, and more costly than it could or should be. And we've made a number of suggestions for proposed reforms that we think could provide elderly Americans reasonable protection against the cost of illness at a price the nation can afford. First, we propose several reforms designed to make the program simpler for elderly Americans to use. The elderly, we feel, should continue to pay a fair share of the cost of the Medicare program. Currently, they pay out of their own resources about 25% of the aggregate cost of the program, and we feel that's a reasonable proportion. But we think they should pay more of those expenses through premiums and less through coinsurance and deductibles than they have in the past. Coinsurance and deductibles create confusion over which services are covered and to what extent. They result in numerous unpredictable payments that fall more heavily on the sick since they're incurred at the time that health care services are used as at the time of illness. And the group also feels that the 2 major parts of the Medicare program should be merged into a single program with one set of regulations governing eligibility and coverage. Second, to limit the health care expenses the elderly incur, Medicare should cover the cost of catastrophic illnesses. No elderly American should have to pay more than $1,000 yearly in coinsurance and deductibles. The cost of providing this protection, about $1.5 billion, assuming that some other suggested reforms are implemented, should be financed through increases in Medicare premiums. To make the program fairer to poor elderly Americans, and despite Professor Cohn's worries on this subject, we do feel that the amount that Medicare beneficiaries pay yearly in premium should be related in some way to their ability to pay. We've suggested that all elderly Americans should pay a 5% surcharge on their income tax, and that 5% surcharge should be dedicated to the financing of the Medicare program. Only 40% of the elderly actually file income taxes because only 40% have sufficient income to require that they do so, so that only those individuals would be subject to such a surcharge. Revenues from this surcharge, as I said, could be used to offset the amount of premiums that are paid by all elderly Americans, thus giving the poor some relief from the high cost of those premiums. Fourth, the Medicare program should cover a well-defined package of basic preventive services without coinsurance and deductible. It should also cover extended long-term care services and home health care services. Because of their high costs, expanded long-term care services we feel should be phased in over about a 10-year period starting in the early 1990s. To make physician services cheaper and provider compensation fairer, we recommended that Medicare should change the way it pays physicians by implementing a fee scale that would reimburse them on the basis of the relative value of the services they provide. We also agreed, and this is a case of coming to the same conclusion, perhaps from somewhat different starting points, we also agreed that Medicare should rely more heavily than it has in the past on prepaid healthcare organizations with proven track records. I would point out, however, that choice is not an absolute good, and that more choice is not always better. You can always have too much of a good thing.
Choice and proliferation of different types of programs will add to the complexity of the Medicare program. What you will have if you were to have a uniform system of capitation with total freedom as to benefits provided, what you would have would be thousands of Medicare programs rather than a single program. And you would have thousands of groups of Medicare beneficiaries with different axes to grind and different problems to bring to their representatives. This would have enormous political consequences for the elderly as an interest group in their ability to protect their interests in the halls of our Congress, which has been substantial, as many of you know, in the past. But I also think that choice has problems from the point of view of its applicability to this particular group of American citizens. The most rapidly growing segment of the elderly population has grown 134% since the Medicare program was started, is the group over 85 years of age. I wonder what choice means for people over 85 when they're faced with an enormous complexity in the Medicare system, an enormous range of possible options for choosing health care programs, and very little in the way of support and information about which programs are better. Elderly Americans generally have impaired mobility, have impaired eyesight and hearing compared to younger Americans. They have trouble in many of the routine activities of daily living, especially this very vulnerable over 85 group. Capitation and choice, it seems to me, have to be approached very carefully in this particularly vulnerable population group. These reforms comprise only a sample of the more than 40 specific recommendations that we have made in the Harvard Medicare report called Medicare Coming of Age, the title of the symposium. Many of our proposed reforms, increased reliance on premiums, catastrophic coverage, the merger of Part A and B of Medicare, could be accomplished within the next 5 years at little or no cost to the taxpayer or to Medicare. For other proposals, as I've mentioned, it would be wiser, we think, to wait until the early 1990s to implement them so the fiscal and technical problems can be resolved. We estimate that excluding long-term care, our proposals, as I said, would add very little to federal expenditures for Medicare. However, our long-term care, our suggested long-term care reforms would be costly to the federal government. We estimate that by the year 2000, the coverage of comprehensive long-term care services could involve expenditures of as much as $50 billion annually under the Medicare program, of which all but about $15 billion would replace expenditures that would be made in any case by state governments and private payers. We haven't made these recommendations lightly with respect to long-term care. They reflect our conviction that given the rapid aging of our population, Americans will pay heavily for long-term care over the next 15 years, regardless of what Medicare or the federal government do. We feel that a universal federally sponsored insurance program for long-term care will, in the end, prove the only practical and efficient and equitable method for protecting the elderly against the looming expenses of long-term care. It's obviously imperative to consider costs in any suggested Medicare reform proposals. Yet it is just as essential to consider other factors that have received less attention in the current fiscal and political climate. Given current drifts of Medicare policy and of our political ideology generally, what kind of protection against the financial cost of illness will elderly Americans have in the year 2000? What kind of access will they have to services? How will we care for the growing numbers of frail elderly who can no longer live alone? These questions deserve study now, if only because changes in policy should be informed by long-range consideration. In 1965, the political process produced a Medicare program that, for all its current problems, was a triumph of humane public policy. It is now time to correct those failings so that at the next birthday of Harvard University and Kennedy School, we can be proud of what we've accomplished in the universe. Thank you.
Well, thank you very much, Dr. Blumenthal. I think you'll agree with me that we've had a very interesting and very comprehensive presentation of the issues, various points of view by the panelists. And now we'll turn to you in the audience for questions or comments. And if you'd like to direct a question or comment to one of the panelists, please indicate to which one. Yes, please.
Question for you in the Medicare project. Coming years ago, a colleague of mine came and visited at UCLA and said that we in the United States have wedded national health insurance for 50 years. The first discussion was in 1916. Then when we decided to do it, we picked the highest risk population, the most difficult group to cover. We almost set ourselves an impossible task to fulfill. My question, and it really is not frivolous, is it possible for a Medicare program to be functional? Is it possible for a program that focuses only on the highest risk group and cuts out all of the other lower risk groups that might possibly balance off some of the costs and some of the other problems that we talked about? Is it possible for a program that focuses only on the highest possible risk group to survive for very long? I don't know who to address it to, but I think it's
well, a very significant question, and I wonder if I might just take the liberty of asking Professor Cohn the first comment, and then perhaps Dr. Blumenthal, since you did in part address the question to our project. Professor Cohn? The panelists can respond from over there.
You'll recall I attempted to answer the question why we did it. And the reason why we did it is because, since it was so high cost, the private insurance market wasn't handling it, and it was a loss, and we injected the political reality into the question that those people needed the protection, and we had to do it. And we did it because, quite frankly, older people vote at least more frequently than younger people do. And we haven't really considered today many of the political realities that go into it. I agree that access and equity and adequacy and all these things are important. But finally, the big question is going to be, and Dr. Roper kind of alluded to it in one way, what is the proper role of government to deal with these problems? That's what eventually is going to be the political decision, not all of these technical questions. Dr. Roper and I and all these other people are going to be sweating over those questions. But when it gets out into the public arena, it's going to be how do people react on what the proper government role should be in this. Now, in relation to your question, I have strongly, over all the years I've done, believed that you ought to cover everybody, and the cost ought to be averaged over your whole lifetime. In other words, if you look over the life cycle of a person, from the day they're born, or 9 months previously, the mother, and to death, you have a situation in which you have very variable costs over the lifetime. You also have very variable costs depending on your morbidity over the years and your disability. Now, my point of view is that that ought to be averaged over your whole lifetime, and therefore you shouldn't have to have a cost which is cheap when you have low cost morbidity on an individual or group and high cost on the others. But the only way you can do that is to have a comprehensive group that represents the total population. In other words, you could in an HMO, if an HMO had young people and old people and middle-aged people and rich people and poor people and sick people and well people, then you can average it all over. But we don't have that very well. But I must say I do enthusiastically agree with Dr. Roper that the only answer we have to that question now is capitation. I suggest a more neutral term like socialized medicine. Because what you're doing, now, you might think I was facetious, but why did I say that? Because when you want to average the cost, you are socializing the cost. By socializing the costs mean you are not relating it to the individual list of the individual, but you're relating it to the entire group and fundamentally whole. So I say yes, it would be a better way to do it. I would entirely subscribe to it, but I think the way we're going is not completely in that direction, and therefore we'll have to finance it. I must say also to Dr. Blumenthal, I think he misunderstood me. I would entirely subscribe to the idea of having a tax for financing any of these programs. What I meant is don't put the income test on the beneficiary side. Put the income test on the income side. Yes, that's the only way I see to answer the problem that you propose.
Dr. Blumenthal, do you want to make a comment?
Well, without discussing the merits of national health insurance, again, I've been screwed by Professor Cohn. I would only emphasize that Medicare has been a remarkably successful program. It has done an enormous amount for people, and it continues to be a politically viable program. So that I don't think that the original architects were mistaken in choosing the route they did. It was the only political option at the time, and it has worked. It needs mid-course corrections, but it has worked. And it may be, in fact, for the next 15 or 20 years, still the only major national effort to provide uniform or universal health care benefits to any segment of the population. So I suspect that we are stuck with it one way or the other.
Yes. The last one, no, the top row, please.
Mr. Newhouse and Dr. Roper both were discussing ways of making the patient's choice a much more factor to try to contain costs. But then Dr. Blumenthal told us about the vulnerability of the oldest age group in being able to make these choices. I'd like to hear Mr. Newhouse's and Dr. Roper's responses, perhaps, to the vulnerability of this age group, especially since a 75-year-old or an 85-year-old is not often found in the supermarket that Mr. Newhouse is discussing in the produce department.
Right. Dr. Roper, you want to start? Yeah.
Arousing the public.
Surely there are some people for whom choices are going to be a problem, but the fact that the those particularly that have mental problems may have difficulties is not a reason to discard the whole concept. In fact, that shortchanges millions and millions of America's elderly who are quite capable of making these kind of choices and would very much like to, and they are. As I said, 600,000 have signed up with these kind of plans. But what's to be done? My answers are, first, I would expect if we had a Medicare program fully devoted to capitation as a form of payment, that there would be beneficiaries banding together to assist each other in sharing information and facilitating those choices. Organizations like AARP and others, I think, would have a useful role to play in helping people through the provision of information and making those kinds of choices. And I think, finally, those people, even those that perhaps have mental difficulties, would be better off under this system, because you have to say, when making a comparison, compared to what? Under the current system, they are left with the yellow pages searching for a doctor when they think they have a health problem. So what I'm proposing is a managed care system in which a person is enrolled in a health plan and has someone looking after their health care needs. I think that's a far better system.
Dr. Newhouse, you make a comment on that?
I wasn't really talking about the role of the consumer, though I could at great length and have elsewhere. I want to come back to what I see as the central problem, whether we have a national health insurance plan or whether we have competition in the private sector. Either way, we have had, since 1940 roughly, we've had costs in medical care go up in real terms about 4 to 6% a year. So before virtually the whole Kennedy School, this has been going on. We are now up to around 10.5% of GNP in medical care, and we're trying to impose some brakes on this train, and I think the issue either way is going to be how do we apply these breaks in ways that don't give us side effects that we don't want or find worse than the cure?
Can I ask a question on this? I'd like to ask Dr. Roper, when you use the term capitation, are you using it only in relation to physician services? Are you using it also with regard to hospital? And are you using it for the combination of both or capitation separately for each?
A combination of both, I envision, as we now have, again, 600,000 beneficiaries enrolled in plans to provide hospital and physician services plus expert services, paid a fixed amount per person per year with strong incentives to manage the care effectively.
And I want to say I subscribe completely to that. I think that is a much, if I understand your point, a much better way than DRGs at the present time for hospital care and for even the most recent regulation that you issued on trying to cap certain types of high-cost physician service. I think it would be a better way, and I think you ought to encourage more people to try that. I don't know whether Dr. Blumenthal agrees with that.
We better...
academic discussion. I'd like to bring it back to reality. What has the Medicare group done about trying to get Congress to enact all this? Was it secretary rule, or did you done with organizations like AARP and the ASRA and the other organizations where long-term care is very important? What have you done with the problem technological debt? In other words, what have you done to prepare this whole legislative act?
Dr. Blumenthal?
You certainly... This is one I think that he will not, this is one topic he won't have to answer. You certainly can find the soft underbelly of an academic without much trouble. We actually, I'm relatively proud of what we've done. Again, to echo Dr. Roper, the standard comparison is important. Compared to what many academic reports do, I think we have worked harder than many at trying to communicate our findings through the media and directly to congressional staff. In several days of briefings in Washington, I think we talked to probably over 100 congressional staff and congressmen about our report's results. Unfortunately, we weren't able to sustain that level of activity for the following 6 months. But we are open to, with appropriate funding, we're open to continuing opportunities to make our views known.
Yes, I think I would just add a word. We have been in communication with many organizations, including the AARP and others, making the information available, offering to give them further interpretations of the data, hoping that they in turn will urge whatever pathways, whatever kinds of legislation they think would be appropriate on the basis of the findings that have been presented. Yes, right?
I think the proposal that accepting it seems that there would be an ethical dilemma for physicians for hospitals if the capitation pie is so big and the security process for salary payments for physicians in hospitals is going to be what's left over after services provided. And I wonder if you could just address the ethical problems of physicians in hospitals that
we've had decades of experience with HMOs, and that has not been a problem under the track record that has been developed. Again, the standard I have to pose is compared to what? There are ethical dilemmas under any form of payment. Now we have a payment mechanism where it is in the direct financial interest of a doctor or a hospital to use more care. Is that ethically something we're proud of? I think I would rather have a system where it is in the financial interest of the plan involved to keep a person healthy, to keep them well, keep them out of the hospital. I think that's an important value to be paid attention to.
far up there. No, just against the wall. Please.
My husband died. I had 300 a month for Social Security, so I could put, I remember my number, not my husband's Social Security number, and every month I take out a lot of money that I don't think, that I will never be able to use because I'm getting this Social Security. Do you think that's fair?
President Kennedy once said life is not fair.
Right now, I think, is there any kind of a program that you might have where you can apply for a certain percentage of it, or I'm not saying that don't you think that something should be done about that, and as much as I'd rather work than not to get money. But for people who have themselves, I don't think that we should be cash for Social Security. When I was young, and I made $12 a week, I couldn't build up my Social Security until it was natural for me to take my question. Now I got
Professor Cohen?
It's a whole complicated problem, but you and your husband probably only paid 20% of the total amount of the actuarial benefits you're going to get under Social Security on your life expectancy. So continuing to pay the present tax, which includes about 15% of it for your Medicare, is not unfair because you were merely paying back the other 80%, which you will get that you didn't finance up until now.
Well, I'm sorry, there's somebody here who would like to ask a question. I think we just can't take that much time for them.
full 1/6 of all elderly patients in capitated programs live in Minnesota. So we have a great deal of experience, and I would not want anyone to leave here believing that it was panacea because we are seeing thicker and thicker discharges, less quality of hearing that I attended that you were a speaker. I think you remember some of the testimony. If the elderly had just remained on Medicare, they would have far better home health benefits than underage most where perhaps they would have 1 or 2 visits. What about quality assurance for the elderly who hook themselves up with HMOs? What is the plan to fix those? Fall through watching how the patients are cared for versus the profit motive of the HMO movement.
Quick answer, under the recently enacted legislation, we will have the peer review organizations looking after the pros starting in January. But again, my answer comes back to, surely there are quality problems in health maintenance organizations, but compared to the rest of the healthcare system, there are problems there as well. In my view, it's on balance, people are better off under a capitated system.
Well, we'll take one more question in order to stay on schedule and all of the things that are happening during the course of these events. We'll have to conclude promptly, so please.
I don't recall the exact figures, but the contribution to premiums would be about $4 billion, and patient beneficiary contributions could be reduced by that amount. It would not by any means fund the entire amount. If I could just have one comment, I don't want to leave the impression that we are opposed to HMOs or opposed to capitation. I helped write the 1978 amendments to the Health Maintenance Organization Act of 1978. I have no problems with health maintenance organizations. I think the problem, the last comment about panaceas is what I would focus on. There is no single answer to the problem of providing health care to the elderly. HMOs would be good for some and bad for others, and I think the question is with what kinds of safeguards, at what rate, and for what kinds of patients do you introduce them, and I think that's the critical issue right now.
Thank you, and I want to again thank all of our panelists and thank all of you.